Dear colleagues, good morning, good afternoon, good evening. Thank you very much for joining us today. We are continuing a global TB program together with our partners and colleagues from other UN agencies and across WHO. We are continuing series of webinars on important TB-related topics, and so we see almost 100 participants. It's very impressive. So, and our focus today will be on multisectoral accountability framework for TB and the ways how we can use this very important and timely approach and tool and mechanism to stay on track in this very challenging situation, to provide further progress towards our very ambitious targets, and to support to many people, to the millions who are still suffering and dying from TB, which is preventable and curable disease. Please, next slide. Multisectoral accountability framework for TB is not something new for WHO, and our organization and its leadership, Dr. Tedros, is promoting heavily the vision that SDG 3, especially during this unprecedented situation, should be put in the middle, in the center of the SDG agenda. Health is becoming more than personal issue, more than issue and problem for the health system. It's becoming big governmental problem, task, and becoming on the political agenda topic number one. So, and the TB as part of the health systems and programs should be definitely a part of this agenda and should be put in the middle of cross UN agencies activities, and I would like to share important targets, very ambitious 3 billion target of the WHO, together with the member states, with the partners. We should provide more access to the essential health services. We should keep the world safer. We should respond to the emergencies adequately. And we have a global action plan for healthy lives and well-being for all, developed also under the request of the member states. Next, please. Multisectoral accountability framework for TB is fully aligned with all these basic principles and priorities and targets of the organization. And I would like to remind you that it was requested in the political declaration of the first high-level meeting on TB to develop a multi-sector accountability framework and support countries in its adaptation and implementation. The whole story was initiated at the Moscow Ministerial Conference in 2017, and we as an organization, driven by the requests and needs, are moving forward with this important tool and trying to support to the countries. Next, please. And another quick reminder, what is MAF about? It has 4 essential elements, commitments, high-level commitments, which should be transformed into the national commitments, and these commitments should be reaffirmed and transformed into actions, concrete actions, and these actions should be monitored. Regular reporting should be in place, and regular review of the progress also should be provided, with the engagement of all sectors, not only health sector, with all stakeholders, and of course with the civil society. Based on the results of this review, we should on regular basis update our actions, and this will be key driver of our progress towards ending TB. Next, please. So as I told, we started our activities since 2017, and we are guiding and providing support to the member states. We're leading and promoting collaboration across UN and across different sectors with the partners and stakeholders. We are developing tools, and you know that another document, the tool to support countries in adaptation is baseline assessment checklist, including important annexes for the civil society engagement, how other sectors should be represented. And I would like to acknowledge all our partners who contributed, and first of all, WHO Civil Society Task Force for their engagement. In 2019, next slide, please. We've launched a collaborative multi-stakeholder and multi-sectoral platform with the partners on World TB Day, aim to coordinate TB response and review progress. And another example of the engagement of partners is 1+1 initiative to scale up youth mobilization. Our role, as I told, the role of Global TB Program is not only to support countries, next slide please, but also to provide global monitoring and review of the progress. And we have a very well-known and important instruments mechanism for this. Well known to you, Global TB report. Now it's available in app version. And if you look at the country profiles, you can find not only essential basic epi data, TB data, but also information on the cross linkages of the situation in the country with other SDGs, with the key drivers such as undernutrition, poverty, alcohol, tobacco, HIV. You know that these are top 5 drivers of the TB epidemic. And it's very instrumental. It helps countries understand what should be prioritized in terms of actions. These slides demonstrate how important is this cross-sector work. You can see based on our latest 2020 report that the number of key TB cases attributable, for example, to undernourishment is growing, and out of 10 million, at least 2.2 million TB cases are attributable to the undernutrition. And it's clear that without addressing this determinant, there is no way to move forward. But I remind you, this was data from which we received before COVID pandemic, and now we can imagine that the situation is becoming even worse. And you can see also example of one of the highest TB burden countries. What are these key drivers of the epidemic? And it's clear that they should be definitely addressed. Next, please. Another important information for planning activities, for prioritizing, could be received from the national patient cost surveys. We've undertaken 70 national surveys, and we can see that the number of people suffering with and facing catastrophic costs, not only due to TB, but also due to treatment and their families, is huge. And you can see for the people with the drug-resistant TB, it's about 80%. It means that 80% of people are facing catastrophic costs. For all people with TB, it's almost 50%. And this issue should be definitely addressed. Next, please. We had this year developed, according to the requests of the UN Secretary General, progress report in TB, and it's another example of the global review. And the progress, of course, even before pandemic was not sufficient, and now we became more affected, and we were even pushed back in terms of progress. So next, please. Now, in few words about collaboration, I'm sure that our colleagues and partners from other UN agencies will present nicely the examples of our collaboration, but of course it happened many years ago. It's not something new, but we are trying to strengthen this collaboration, and one of the clear examples is collaboration with USF on ending TB in children and adolescents. A roadmap was launched prior high-level meeting on TB, and you can see leadership of two organizations directly involved in this process. Next, please. Another example is collaboration with the UNHCR on TB prevention and care for refugee population. We are working very closely, and the new guide, updated field guide will be released quite soon, and it's another important area of joint efforts. Next, please. IOM is another good partner for WHO, and we are working closely with them on TB and migration. They've been portal, TB and migration portal developed and hosted by IOM. We've developed many important tools and working very effectively in many countries. Next, please. And other UN agencies and like UNAIDS, ILO, FAO, OIE, WFP are also working closely with us, and these are few examples of the results of our joint efforts. Of course, it will be continued. But this collaboration happens, next please, not only at the headquarters level, of course, but first of all at regional and country level. And you can see another example when 14 UN agencies joined forces and to end the epidemics of 3 diseases, HIV, TB, and viral hepatitis, and demonstrated it during the launch of the first ever UN common position on it. So these good examples, of course, should be shared broadly, and this approach should be continued. More recent example, joint mission together with colleagues from many UN agencies, as well as with the colleagues from NCD Department of WHO, TB and NCD joint mission to Nigeria. It happened just before the pandemic, and it demonstrated huge potential. We can address health issues. We know obvious linkages between TB and diabetes, as I told, alcohol use, tobacco smoking, and this approach hopefully will be continued once we will overcome this crisis. Next, please. I will not go into the details. All the information will be shared, but of course, all our life divided into two pieces. But we were very seriously aimed to push this multi-sectoral agenda, because seems in the current situation, it's becoming more obvious that this is the only one possible approach to address big issues, big epidemics, and in our case, so-called old epidemic of tuberculosis. Only by joining efforts across the globe, across UN agencies and partners. Next, please. A few information about where we are. We were, as I told, pushed back, and COVID-19 so has put NTB progress at risk. And you can see that we are monitoring on the monthly basis now a situation in the countries, and we see that sharp drops happens in many of them. And now, in addition to 2.9 million missing people, we have another 1.4 million at least missing. This gap and limited access, unfortunately, is becoming a huge issue. Next, please. You can find more detailed information at our website about situation in the highest TB burden countries. But again, these issues and problems should be addressed only by collective efforts. Next, please. Otherwise, we are predicting against, based on our modeling, up to 500,000 additional TB deaths. And it's preventable and curable disease. And even in the current circumstances, we can address it effectively, but jointly. Next, please. And so these are a few other examples how we are addressing issues related to TB and COVID. So, and now, next slide, please. Looking ahead, how to advance these multisectoral actions and accountability. So we would request all the participants, all the interested parties to join us, to join forces and follow these priority recommendations from the UNHCR report, and try to contribute based on your mandate and according to the agreed priority into the TB agenda. At the end, we will benefit all, and not only seeing progress in TB, but it could be used as an effective model of the multi-sectoral collaboration also for other sectors and for other SDGs. So I will stop with this. We have very busy agenda, and with pleasure give floor back to Marcia for the introduction of our panelists. Thank you very much.
Thank you very much, Teresa, for your rich presentation on the progress in fostering and strengthening multi-sectoral collaboration. As we heard, there is encouraging progress in harnessing high-level leadership and multi-sectoral engagement to end TB. And this aligns with WHO's vision to strengthen collaboration with partners and stakeholders, as exemplified by the Global Action Plan for Healthy Lives and Well-being, or short GAP. Under this Global Action Plan, the 13 agencies involved are better aligning their ways of working and provide more streamlined support to countries to deliver on the health-related SDGs and related international commitments to health. To explore more on this topic, I'm now turning to Hendrik Schmitz-Guinot and Isadora Quick from the Secretariat of the GAP. Colleagues, the floor is yours.
Thank you very much, Marcia, and thank you for inviting us to present the Global Action Plan for Healthy Lives and Wellbeing for All, and to show how it can support multisectoral action, including in the field of TB. Okay. So the Global Action Plan was launched in September 2019 at the UN General Assembly. Its goal is to accelerate progress towards the health-related SDGs, leaving no one behind, including in the current context of countries' efforts to recover from the COVID-19 pandemic. And this through a partnership of 13 multilateral agencies. ILO has joined the Global Action Plan in January this year. And we've published the first report in September 2020 and are currently finalizing the second progress report, which will be published later this month. So very briefly, the SDG 3 Global Action Plan implementation is based on 4 key commitments, which are to engage countries and work better with countries to align the signatory agencies' actions and activities behind national priorities and plans. The second commitment is to accelerate progress, in particular through joint work in 7 accelerator themes, and through a commitment on gender equality. And then align by harmonizing operational and financial strategies, policies, and plans. And finally, by accounting for the progress made, and mainly, of course, through the publication of the annual progress report. So as I mentioned, there are accelerator themes. There are 7 accelerator areas. And in the interest of time, I won't go through all of them. You can see them here on my slide. But all of these sectors are really cross-sectoral, and the signatory agencies believe that working closer together in these areas specifically will have a catalytic impact and help countries achieve SDGs. And finally, the implementation of the Global Action Plan is really focused on countries. The idea is that the closer collaboration happens at country level. And under the SDG 3 GAP, collaboration has scaled to 37 countries, which are in all of WHO's region. And increasingly, we are really seeing that collaboration at country level is not only limited to one accelerator area, but actually we're seeing collaboration across accelerator areas and new synergies being built across these areas. The idea is really to build on existing collaboration mechanisms at country level. So not invent anything new, but use what already exists in support of countries' national priorities and plans. And the progress report, which will be published soon, includes country case studies, which really showcase how the collaboration, the closer collaboration has happened and how it has been put in place and what it means for greater impact on different outcomes. And I'll now hand over to Hendrik for the next slide.
Thank you, Isadora, and thank you for the organization of this webinar. Can we have the full slide? And I think there was a comment that there's no audio. Just wanted to confirm that you...
No, yeah, don't worry, there is audio, thank you.
So
that seems to be the case. Great. Yes, so I'll touch briefly upon some of the points where we thought, this overall commitment of now 13 multilateral agencies to closer collaboration can be helpful for the efforts also focused on TB, and of course achieving this effect sort of beyond a specific disease, but on the overall achievement of SDG 3, but also the other health related goals. And I mean, we heard about the context already. The COVID pandemic has thrown progress even further off track than before, and collaboration, closer collaboration, working across sectors, working across agencies will be key to support equitable and resilient recovery to the SDGs. And what we also see from many countries coming out is PHC-focused approaches to address and drive forward the recovery. But collaboration, of course, is also challenging. We tend to all have our more narrow mandates as agencies and sort of funding streams. But the Global Action Plan provides this overall commitment to bring the actors more together, align with the country priorities, and try to address some of the barriers which have limited collaboration in the past. And we're very much looking forward to the presentation from the different agencies, many of which are signatories to the plan, also to hear from them the concrete experience, because the Global Action Plan is also meant to be a learning platform and sort of learning from the examples in TB in some countries, what can we scale to other countries and what can we scale to other areas, and how can we integrate that with this accelerator approach. Isadora mentioned the accelerators, but primary healthcare financing for health, addressing determinants of health and working with communities are some of these key areas where there's these commitments to bring the work of the different agencies together. And always with a strong focus on equity, enhancing gender equality throughout the programs, and keeping a focus on the country level and making a difference there. So with these, I think we'll end our presentation, but we would like to also use this opportunity to invite you to reflect sort of if this collaboration can help you in your countries, and please reach out to us and let's discuss how we can bring the different actors together and adding this overall SDG lens to the important work you're doing on TB. But the last slide just shows the agencies. Maybe we can go to that while we hand over, so you see who's engaged. Thank you.
Thank you very much, Hendrik and Isadora. We'll now turn to our fellow panelists from other UN agencies. Our first panelist will give us the perspective of the world of work, where TB can adversely impact both employees and employers. ILO and the Global Tuberculosis Program have been collaborating for many years in addressing TB in the workplaces, and more recently also in advancing social protection and health in line with the SDGs. I would like now to invite Afsar Sayed Mohamed, Senior Technical Specialist at ILO, to take the floor.
Thank you very much, Marzia, and I hope you can see my screen.
Yes, we can.
Perfect, thank you. ILO, as many of you would know, that is an international labor organization that's tripartite in nature. So we work with governments, employers, and trade unions. Whatever we do, we bring all the three actors together to take actions in the world of work, which all the three players have a very important contribution to make. We are addressing in our TB program, we are addressing the co-infection of HIV and TB, because this was also highlighted in the earlier presentation by Dr. Kasiva. And one thing that we are trying to do is to see that the shocks that families accept because of whether they are having TB or HIV is the cost. They can't work, they don't go to work, they lose their income, and therefore there's malnutrition, they're undernutrition, then treatment doesn't work very well. What we are trying to do and why we are focusing in world of work, because it actually contributes to all the three pillars of ending TB strategy. First thing is takes care of the patients. And in our perspective, patients don't just need treatment, they need the support of their employers. That allows them to keep running their households, keep getting the income, eat well, and respond better to treatment. We also come up with policies and supportive systems in the world of work, because workplace policy for us is a framework which allows employers to commit to ending a particular infection or taking care of their employees. So we go through a policy framework in workplaces, and we also take up research and innovations as we go along. There's a short video here, but I won't show it in the interest of time. But the idea is we made short videos and PSAs, which in collaboration with the Central TB Division, Ministry of Health in India, which were used. And I'm happy to have Dr. Raghuram Rao also in this call, who will also speak and share and talk about this collaboration a little later. The ILO's approach basically has these three pillars: a human rights-based approach that protects rights of workers to get, first to have prevention services, then to have treatment in place, and then to have all other support that employer needs to provide them. We have prevention programs in workplaces. We train peer educators. We train. We make use of the existing structures in workplaces, which are like occupational safety and health structures, and sometimes health and wellness programs of enterprises. And we try to, through those programs, we try to work on TB and HIV. And treatment care and support is the third important player. Whatever we do is grounded in the ILO conventions, which are international labor standards to protect rights of workers. And so in this particular thing, ending discrimination, since it's very important. So we have this ILO convention 111 that's always put to use, but we also have important ILO instruments for addressing TB as well as HIV, which is what you could see here. We have this ILO recommendation number 200 on HIV, which also addresses TB. We have developed materials. We are working in several countries, in India, South Africa, Kenya. I'm particularly talking today about India. Work in India started in 3 years ago when we started collaborating with Ministry of Health, and we brought in the Ministry of Labor and Employment, employers and workers organizations to work together with Ministry of Health. We already were working in India on HIV programs for over 10 years, and we are trying to bring in all those experiences into the TB program. We had a national steering committee headed by the Ministry of Labor, and now we have inducted Central TB Division into that committee. So we have a steering committee at the national level, which works and reviews the program. We had a policy, national policy for workplaces to address HIV. We looked at that, and through private sector consultations and through employers consultations and national consultations, we have developed a policy framework for addressing HIV and TB in the world of work. The links of these policies are all addressed. So whatever documents I'm talking about, they are for everyone to look at. If you click on this link, it takes you to the Ministry of Labor website, where this policy was introduced by a message from the Secretary, Ministry of Labor. We have developed advocacy materials, communications materials, and along with Central TB Division, we have used them in the national campaign to address stigma and discrimination, to talk about workers, because majority of those who have TB as well as HIV are in the working age, and majority of them work in the informal economy. Therefore, it's very important to do advocacy and draw the attention toward these groups of workers. We are helping, we have developed a training manual for enterprises. We train peer educators, as I said. We have developed some good models. Some good companies are already engaged in TB program. We have documented their work on our website. And now in collaboration with Central TB Division, we are taking a study to assess the impact of TB and MDR TB on workers in the formal and informal sector. The preliminary results that seem to be coming are showing there's a huge impact. People are losing their daily wages when they cannot work, and therefore that it will be used to do more advocacy. We got all the national level employers organizations together to commit to ending TB. They signed a common statement of commitment. And based on that, now we are going to enterprises, both in public sector as well as private sector. One example is coming from a company, it's a transport public sector company in Mumbai, where they have a long-standing program based on policies that they have already developed. And here you see how much the support of an employer is important for the worker. This lady says, I could beat TB because I had job security. In BEST, which is the name of the company, benefits like paid leave, free medication and hospitalization, and thoughtful colleagues bring great comfort. Since we do a lot of trainings of peer educators, this creates an atmosphere that there's no discrimination. We are also working with Coal India Limited, which has 6 subsidiaries in different parts of India. Management is fully committed to ending TB as well as HIV. And the beauty of this work is it's not just confined to the regular employees. They actually reach out to beyond their regular employees. And that's where, as part of their CSR effort, they also expand the reach. So what can the world of work do for this multi-sectoral response? By engaging with Ministry of Labor, employers, and trade unions, it allows us to reach out to workers, both in the formal and informal economy, and use the existing structures to contribute to early prevention as well as treatment and treatment adherence. We are working through employers' policies, which are supporting adherence of treatment. We are trying to contribute towards ending discrimination, and we're also trying to use the CSR efforts of enterprises to reach out. So in closing, we are working on TB and HIV together, and bringing in these 3 actors to work with Ministry of Health as well as the civil society organizations. It is a great thing to do. One thing that has worked very well is engaging people living with HIV as advocates in the program, and we did the same thing for TB. We brought in people who have been cured of TB, and when they spoke to enterprises that, I completed the treatment thanks to my employer support, and this was extremely useful for me. So those kind of messages and involving people who had the TB and now are cured of it is proving to be very, very useful. Thank you.
Thank you, Afsar. As we heard about the India project, I would kindly invite Dr. Raghuram Rao, Joint Director TB of the Ministry of Health and Family Welfare of India, to share his perspective.
Thanks, Mazia and Afsar for setting the tone, and thanks to all the panelists for this opportunity. It's like Afsar said, we have been working very closely with ILO, and it's been like a catalyst working with the different ministries and helping us link and come up with strategic documents and workplace policies. And a lot of work that has already been done has been showcased in the previous presentation by Afsar. But now we also going forward with that and scaling up these workplace policies interventions at the state level. Health is being a federal structure, is a state subject in India, and everything, the policies that is made at the national level has to be adopted and taken forward by the state level. So we are working with all of them, all the state governments, and the districts to take this up, and quite a few of the states have already adopted these policies and started implementing the workplace policies, cutting across public and private sectors, especially the informal sectors. Those are very important for us because a large chunk of our workforce is working in the informal sector. And the key learnings from this project with the ILO, the materials, the tools that have been developed are are being used extensively. We are working with corporates, and we have started a program called the Corporate TB Pledge, wherein the corporates pledge and also commit their CSR funds to work towards tuberculosis, not just in the environment at the workplace, but also in the surrounding communities. They are coming even forward to adopt certain districts or local geographies to provide the ancillary support and gap filling in the health system if required, and going and doing community level activities to address tuberculosis at the ground level. A lot of webinars, especially during the COVID times, has been conducted at the state level by these functionaries, by these corporates. They are leading it. The associations of various corporates, CII, FICCI, ASSOCHAM, all these people are working with us, and we have had series of webinars in 2020. And going forward, of course, we have had a huge impact of COVID. We are going through very troubled times in the second wave now, and I'm sure we'll rebound back with the TB program in the same manner, and in fact more stronger than before, because now the health systems are well prepared in terms of rebounding back from COVID pandemic. The SOPs are in place, the infrastructures have been strengthened, a lot of policies have been modified, tweaked to suit the community and take drugs and diagnostics as close to the community as possible. So lots of efforts going on, and I'm sure the efforts the from and
Dr. Rao, unfortunately, we have lost you.
companies. Am I audible?
Kindly try to switch off your camera because the connection seems unstable.
Am I audible?
Now we can hear you. Can you hear us? I think that Dr. Rao connection. Oh no, you're back. Yes, but we can hear you. You are on. Okay.
Am I back?
Yes, you're back.
Yeah, sorry for the connections. Yeah. So what I was saying is that now, as a TB program, we have multiple MOUs that we have with the line ministries, like the labor and employment, the railways, the defense, the paramilitary, the the Ayush, which is the alternative system of medicine, and then with the tribal affairs. So lots of line ministries have agreed to work with us, and we are learning from the COVID experience of going full blown and going on a whole of government approach for tuberculosis. Like we have a health in all policy, we are pushing towards a TB in all policy with the with these line ministries. So that's just in short what I wanted to support and add on to what Afsar was saying. So sorry for the technical glitches in between, but thanks for this opportunity, and happy to take this forward. Thanks.
Thank you very much. Your message was very well heard. And thank you also to Afsar. We would like now to move to our next panelist. We heard from previous presentations that the Global TB Program has led efforts in advancing multisectoral action, engagement, and accountability to enable countries to reach targets and save lives. Since the release of the Multisectoral Accountability Framework, Pakistan has moved forward in advancing its adaptation and implementation. And the country recently completed the baseline assessment of the MAF-TB. I hence invite Laik Khawaja, National Professional Officer of Pakistan, to take the floor and present experience of the country with the MAF. Laik, the floor is yours, but we can't hear you. Laik? Great.
Yes, thank you very much. Thank you very much. And thank you very much for providing the opportunity to share the Pakistan experience on MAFTB in the EMER region. We all know that Pakistan is the 5th highest on the list of the high TB burden countries, and in AMRO, 70% of the burden is shared by Pakistan. And Pakistan is facing key challenge of missed TB cases, which is further compounded by the COVID-19 pandemic, with the fall of more than 18% in 2020 as compared to 2019. So as we see ourselves today, Pakistan is almost missing more than half of its estimated burden from notification. So this is a big concern, global always at the regional level and in the country level. MAF is one of the key strategic area, which is part of the National Strategic Plan of Pakistan to end TB. And we know in Pakistan, we have a devolved Ministry of Health. So the provinces are like taking the leads in the implementation, but the central role is limited to the policy making and adapting the national guidelines in country context. We see progress made in Pakistan after the United Nations high-level meeting. And immediately after that meeting, by end of 2018, we had a high-level mission from Global TB Program, Dr. Teresa, and we were joined by the Dr. Anna from the regional office. And they had very good interaction with the federal level. And also they paid a visit to the province of Punjab, where they were met the governor of Punjab and the health minister. We see like Pakistan has contributed in this regard, and Pakistan is signatory to the international commitments on the forums of, like we have the SDGs, we have the NTB, and the United Nations high-level meeting political declaration. We are signatory to it, and some key actions which we see on which we have moved during the last year or so is like that. We have now a strategic plan, a national, also our provincial strategic plans, which are aligned with the United Nations high-level meeting targets. And we have monitoring and reporting mechanisms in place. We have a regular like surveillance meetings at the district level. We have a DHS2 instance in place for TB. We have conducted a prevalence survey, and we are planning for another one in the days to come. We have been conducting the epidemiological reviews, and then we have a joint program review missions every 2 to 3 years. Along with the partners, we review the program. But I think there's still a lot to be done. There is a need to strengthen all components of MAF by bringing in more focus on the multi-sectoral approach and accountability. It's just as we said, thinking about out-of-the-box solutions and business unusual. As Teresa in her opening remarks has rightly mentioned, that the drivers of the TB epidemic are outside the TB world. We cannot win this race until we have a wider stakeholder involvement and sectors beyond health. So the launch of MAFTB framework document and checklist, Pakistan took the initiative of taking all provinces on board. And NTP took the first step of conducting the MAF assessment on WHO checklist. And WHO provided a technical assistance in this regard. I'm very pleased to share this information that we have completed the assessment, and on 7th of May this month, National TB Control Program and the ministry is sharing the findings of the assessment, and it has recommendations and an action plan how we move forward with adopting this framework in national context. Some of the key actions I will quickly summarize that, like, we do have the commitments, but the translation of the political commitment into financial terms is very important, and we need to really invest in our domestic money and domestic financing for TB. This is one area, and ministry is also already taking up this issue of, like, we need to, they're working on a PC1 to support AIDS, TB, and malaria. As far as the actions is concerned, there is a strong recommendation to have high-level forums for SDG and TB agenda. And very recently, on the occasion of the World TB Day, when WR was there with the governor of Punjab, which is the highest TB burden province, and governor has announced a task force for TB-free Punjab and hepatitis-free Punjab. So we are just about waiting for the notification to happen, and then we will be really supporting the province to adopt the framework in the provincial context. So also there is a recommendation for a district-led approach, and then there is a plan to pilot in selected districts so that we see it how we can really do it in the district level, which is the lowermost level of the implementation in the country. And then we need to engage the media because they have a very important role, and TB stigma has been further compounded by the COVID-19 epidemic. As far as the monitoring and reporting is concerned, I think we need to expand the scope of monitoring by including MAF and MAF indicators, because we have been looking into the TB problem with the TB lens, but now we have to wear a MAF lens, and we need to link it with the DHS2 as well. E-learning platforms is one of the recommendations coming out of it by incorporating the MAF TB in the national training programs. And then we need to have a very a higher level national review mechanism using the lens of MAF TB. There is a express need for the technical assistance from Global Fund, from the WHO for adopting the MAF TB and piloting in selected districts. And the action plan is proposing that we need to get it done by next year, by September 2022, so that we are ready for the year 2020. We'll have the next high-level meeting. So that's all from my side. Over. Thank you very much.
Thank you very much, Lake. We move to our next speaker, who is going to present about migration, a key phenomenon that characterizes the world of today. Several determinants of health and TB interplay to increase the vulnerability of migrants to tuberculosis infection, TB disease, and poor treatment outcomes, making migrants, among others, a key population for TB. I hence invite Carlos van der Laat to tell us more on the topic and draw example from the IOM response in the Middle East as Migrant Health Division of IOM Geneva.
Thank you very much, Marcia. I don't know, I am sharing this. Can you confirm? Yes. Okay, no, thank you very much. It is a great pleasure to be part of this panel. I will start with 4 initial thoughts, which are indeed realities and respond to the context of many migrants and displaced people in the world. Sorry, I don't know why it's not moving. There you go. Yes, so basically, I will start with these 4 thoughts that affect directly the outcomes of the TB response. These are realities that are key to understand the importance also of an urgent multisectoral approach. So the first one is that, yes, although leave no one behind sounds everywhere, we do have big groups of people that struggle every day to survive, who are still left behind. In many countries, unfortunately, the migration status, the documents, the nationality is still a big barrier to access health services. It is still a cause for stigma, and it is a real threat for public health, creating even more challenging conditions for achieving the global TB targets. Part of this lessons learned with part of the lessons learned with COVID-19 is that no one is safe until everyone is safe, and this is very true, and this is why inclusion is not just a fair thing to do, but also the smart thing to do. For all infectious diseases and outbreaks, inclusion is the only way to achieve a positive outcome. And this is also very true for tuberculosis. If we don't include human mobility in our daily thoughts, our plans will never reach a positive outcome against tuberculosis. The third one is people move. So we are convinced of the big need for multisectoral action to address the broader social determinants of tuberculosis. But well, those determinants also move. Migration is a determinant of the determinants of health, and basically not recognizing human mobility will not allow the achievement of the global TB targets. As easy as that, people move, and so needs to move the response also. We need to move with them, adjust to the dynamic of the human mobility. So multisectoral, regional, binational, migrant inclusive approach is needed. And UN agencies, NGOs, national TB programs, all response needs to consider mobility. Mobility is very, very important because it's part of our language, it's part of our context. And that's why we need definitely to have a more explicit language in terms of inclusion of migrants. National and regional plans need to have a specific narrative and specific actions also for inclusion of migrants, refugees, displaced as vulnerable populations. And finally, the big gap in thinking that tuberculosis is only a health issue and that only the health sector should respond. Migration basically helps us understand the importance of this multisectoral approach, the importance of involving labor, housing, education, migration, foreign affairs, to include civil society, to include representation from the community, not just that community, but also the migrant community and also the host community, and basically to include religious and local leaders. So a good example of a multisectoral approach is the multi-country project funded by the Global Fund, known as the Middle East Response. Basically, this project responds to complex emergencies where violence have forced millions of people to move within and across borders, where COVID-19 pandemic has also complicated the already complex political and economic context, with ongoing conflicts and civil unrest in Syria, Yemen, Iraq, where the breakdown of existing social and community networks have severely impacted also public services, with serious public health consequences. So this is a very important project in terms of multisectoral approach, and it's also a very interesting project because it includes Jordan and Lebanon as neighboring countries that are also affected due to the massive influx of refugees and migrant communities. And so this is only to show how complex it is when we talk about sectoral. It sounds so easy, but it's not easy. Many people involved, many experts providing their opinions and also requesting a response. Many groups advocating to be included, many different approaches, different mandates, different needs and interests. But as hard and challenging as it could be, as important also it is and key to obtain positive outcomes and to reach the desired targets. So to finish, countries need to be accountable for the people in their territory, also accountable for migrants, displaced, refugees, all people in their territory. There should be increased emphasis also on the need for effective regional and cross-border coordination. This usually is a big gap in terms of the response. Usually we work very in a national wise type of approach, but yeah, basically we need to improve the cross-border coordination and collaboration, especially when we talk about continuity of care. And this implies dialogue, harmonization of testing, treatment, and care protocols, and also very, very important, the establishment of regional electronic data systems. So that's it. Please confirm IOM's interest and availability to support all activities at country, at regional and global level as technical, operational, and policy expert on migration and mobility. Thank you very much for this opportunity.
Thank you very much, Carlos, for this presentation. Before moving to our next panelists, I would invite all the attendees to send and write their questions in the Q&A box, because panelists have already started to answer them. So do not hesitate. WHO, the Global TB Program, has been collaborating with the United Nations High Commissioner for Human Rights for many years. The work resulted, for example, in the development of an up-to-date field implementation guide for TB care and prevention in humanitarian settings. This guide process has proved as an excellent means to strengthen cross-agency collaboration, as well as strengthening the support to TB care and prevention in these challenging environments. We would like to hear more on the topic from Anne Burton, Chief Public Health Specialist at UNHCR. Anne, the floor is yours.
Thank you very much, Marzia. Good morning, everybody, and thank you for giving us the opportunity to speak. UNHCR, the UN Refugee Agency, the UN High Commissioner for Refugees, supports our TB programs in refugees globally. Our level of engagement varies according to the context, as well as the state of the national health services. But one thing that is in common, we have done a survey on 48 refugee hosting countries in 2019, and 100% of countries include refugees in their national TB program. So one thing that is constant is that we are working very closely with national TB programs. What I'm going to discuss today is just to present to you 3 areas of collaborative action, and then just very briefly touch on UNHCR's programming with partners as part of the national TB program in South Sudan, before one of the panelists from South Sudan will go into further detail. Just waiting for the next slide. Not sure why it's not moving, actually.
Do you want to present from our end, Anne?
If that's easier, can you do that, or?
Yes, just try once more with the arrow or with your mouse. Otherwise, we can present for sure.
Yeah, it's not, for some reason, it's not working.
Just give me 1 second. Can you see your presentation now?
Yes.
On this? Okay.
Yes. So thank you very much. Can we move to the next slide, please? So this was mentioned by the director, Dr. Teresa, just to mention that WHO and UNHCR, along with the US Centers for Disease Control, putting the finishing touches to an update of a document on addressing TB in refugees and displaced communities. This is an operational guideline that was developed. It's an update of a 2008 document. It recognizes that The UN has committed to end the TB epidemic by 2030, and TB remains the leading one of the leading infectious causes of death globally. And it's, as my colleague from IOM mentioned, refugees and other displaced populations are being left behind. So the document contains an overview of key actions in preparing for and delivering effective TB prevention, treatment and care services for refugees and others in humanitarian situations. It also includes multisectoral actions, particularly nutrition, food security and social protection, and a strong emphasis on community engagement. Next slide, please. The other area that I wanted to highlight here is UNHCR, along with WFP, are co-sponsors of UNAIDS, and we are working within UNAIDS as to collaboratively address TB and HIV-related TB in humanitarian settings. Although TB is preventable and treatable, it is the leading cause of death among people living with HIV. This is because less than half of estimated incident TB cases among people with HIV are being diagnosed and treated appropriately, and conversely, less than 60% of TB patients are being tested for HIV. And these figures are likely to be higher in humanitarian settings. So with the new global AIDS strategy that has just been launched, it contains an integrated approach to HIV and TB with high-level targets and commitments, of which 90% of people in humanitarian settings having access to integrated TB, hepatitis C and HIV services. So we are working together to strengthen integrated services for these populations. Next slide, please. The third area we've seen also talked about is the economic burden that TB places on individuals and households. Due to TB, people face costs or suffer income loss equivalent to an average of more than 50% of their income. And this places the heaviest burden on the poor, the most poor and vulnerable, of which many are in humanitarian situations. ILO and UNHCR are collaborating on social health protection in refugee situations, including for the most marginalized, those with TB and/or HIV. This is not only based on global guidance, but also collaborating at country level. And this contributes to ending the goal of protecting TB-affected families from catastrophic costs. UNHCR also works with partners in refugee settings, conducting socio-economic vulnerability assessments and supports the most vulnerable to meet basic needs, including through cash assistance. Next slide, please. Just very briefly, I wanted to touch on South Sudan. South Sudan is hosting more than 300,000 refugees and nearly 400,000 refugee returnees that have returned since the end of 2017, spread over 21 different locations throughout the country. There are 10 refugee camps. We have been working as part of a global fund supported through EGAD integrated HIV/TB program in 7 countries throughout the region, 4 of which UNHCR is the sub-recipient. So in South Sudan, we are working very, very closely with the National TB Program and with other stakeholders, including at state level, with WHO, UNDP, and also with UNHCR's partners to strengthen HIV and TB services. Significant progress has been made. I'm not going to go into all of the progress here, but just to say that there has been much progress made in decentralizing access to diagnostics for HIV and TB in South Sudan. Next slide, please. In terms of multisectoral action relating to our work in South Sudan, closely integrated with nutrition and food security. In terms of supporting those that are on TB treatment, but also linking, for example, those that are in nutrition programs, linking those with TB services if they fail to gain weight or fail to respond to nutritional treatment. Persons that are diagnosed and under treatment with TB are also referred to WASH and to shelter services, recognizing the impact that inadequate living conditions contributes to the spread of TB. And then community-based protection, working with communities to reduce including influencers at community level, including religious leaders, community leaders, on reducing stigma and discrimination associated with TB. Next slide, please. Sorry, previous slide. Sorry, just 2 more slides. So just, so in terms of the South Sudan TB program, and I am not going to speak very much about this, but just in terms of the collaboration, the multisectoral approach relating to refugees. As I said, the refugee program is very much integrated within the national TB program, which has a multisectoral approach to TB and involvement of various actors, including UN agencies based on their areas of expertise, and NGO and civil society partners, particularly providing support to services at field level. Last slide, please. So in terms of the opportunities that have been noted with our engagement with the National TB Program in South Sudan, the key factors that we feel have contributed to the successful collaboration include that the national strategy, policy and guidelines have been developed in line with the global documents. The very strong leadership from the National Ministry of Health and also state level, the technical coordination amongst partners, given the high staff turnover and the challenging conditions, the frequent capacity building, and also the strong levels of community engagement. Thank you.
Thank you very much, Anne, for your presentation. And I would like now to invite the National Program Manager of South Sudan, Dr. Apal Tobi Madut, to take the floor while I'll share her presentation.
We want to share this one in this slide.
Dr. Madut, we didn't receive your presentation actually, so could you share from your end? Would that be possible?
I will just go through it then if you did not get it.
Yes, thank you.
Sure. Okay. Share it. Thank you everybody first for inviting South Sudan to attend this meeting, the Multisectoral Accountability Framework for TB. We always look forward to engage in such high-level meetings so we can learn and also have collaboration with other partners and stakeholders. So thank you very much, Dr. Ant Batoon, for your presentation. UNHCR has been always our partner supporting us in fighting TB here, even though they concentrate mostly in the refugee, but also their support has a great impact in South Sudan in terms of ending TB. So for my presentation, I will focus in few information that were not shared by Dr. Ann for the sake of time, because I have 5 minutes and I'm not sure whether my voice is clear. Am I clear? Okay, thank you. Yes. Yeah, so as Dr. Ann has mentioned that the national TB program here in South Sudan, which is located inside the Ministry of Health, is the main stakeholder that is championing TB in South Sudan. For the introduction, we would like to first highlight few things in terms of the geographical areas under the NTP and the partners. In regards to TB services, the TB program here at the national level is supported by the Global Fund. The grant from the Global Fund is what is mainly supporting the TB services here. And it encompasses under the grant is being taken care of or by the principal recipient, which is in this regard is the UNDP is our principal recipient for the main grant, but there is also a catalytic grant through the IGAD, and that's where the UNHCR come in place. In terms of the number of facilities that are giving TB services in the country, there are 105 TB diagnostic and treatment facilities under the TP, and in addition to facilities supported by our SRs, which are the implementing partners. As so far, we're having AAA and CORDATE supporting the implementation of TB services in the country. I would like to also give information in terms of the status of TB in South Sudan. So in terms of prevalence of TB, comparison from 2020 and 2019, the proportion was 227 per 100,000 population as of Q4 of 2020, which is a bit higher compared to 2019, which was 149. New cases and relapse cases, the total is 15,707, which is increases in 2020 compared to 2019. By looking at these two numbers, the cases, there is an increase in terms of the new cases of TB in the country. Another challenge that I would like to share is the MDR TB, which is the multi-drug resistant TB. We are not doing that much. The target was 220 cases. We only reached 101, which is very low compared to the Global Fund target. Childhood TB, so far we are having 2,599 out of 15,707, which is 16.5% compared to 11% in 2016. Yes, it may show high, but yet we are not doing much in terms of case notifications and for childhood TB. That's an area that South Sudan needs to work hard on. As far as TB with co-infection, particularly with HIV and AIDS, which is very a challenge here in South Sudan also, we are at 11%. The program is improving. It was 14.7% from the first survey done in the country. However, because it has been a couple of years without any survey done, so the number, we still have a lot of work that needs to be done in the area of TB and HIV co-infection. Treatment success rate, we stand at 85%, and the death rate is 1.8%. Coming to the cure rate for TB, the cure rate is not separately captured, but it is captured under the treatment success rate and treatment outcome, because treatment success rate includes the cure plus the completion of the treatment. So looking at this, this is very important indicator that we need to always look at, which is the cure rate. Since TB is curable, so we have to look at it both in people living with HIV and in general TB patient. The overall accomplishments, the major accomplishment of the program during the reporting of the quarter, generally, first we have done in 2019, we did a survey for TB, like the epidemiological survey. That's one of the achievements. We also did a review for the TB program by the end of 2019. And now we are implementing the strategic plan, which is National TB Program Strategic Plan for the 5 years, starting from 2020 to 2024. So those are few achievements in terms of guidelines and how are we looking at the progress made at the country level. Provision of leadership in undertaking the comprehensive TB program review exercise throughout the country was very supportive, that the leadership gave us all the support along with the partners, and external reviewers were also part of the exercise. We also came to support the high impact facility, and especially we call them the hub here in South Sudan. The interventions are undergoing, yet issues of like multi-drug resistant TB that I've already mentioned, and the co-infection with HIV, those are the few challenges that I can add in this presentation.
Thank you, Dr. Madoud. We are running out of time, so can we kindly ask you to wrap up your presentation?
Wrap up. Yeah. Okay. Okay. Another one, what we have done recently, we have formed a committee across border between South Sudan and Uganda by the support of IGAD, and between South Sudan and Kenya. So now we have a cross-border intra-country and inter-country cross-border committee that will look at the issues to do with the TB across the borders. Issues of human resource building of the capacity are some of the challenges that we are facing. And we are also advocating for the leadership of South Sudan to put in some fund in order to bridge the gaps, because we're solely depending on the partner support through the Global Fund and the IGAD.
Thank you very much.
So I'll stop here.
Thank you very much, Dr. Madoud, for your intervention. I would inform all the participants that we are running out of time. So if you can, but we still have a couple of more presentations and contributions. So if you can please stay with us 15 minutes more than planned. We are moving now to the next panelist. We are going to talk about. We're going to talk about malnutrition and actually food security and nutrition. In fact, during humanitarian crisis, access to healthcare services and availability of drugs for people living with HIV and TB may be disrupted, and patients may find it hard to meet their nutritional needs, further risking their health. I invite now Michael Smith, Partnership Officer of Nutrition Division at the WFP, to take the floor and tell us more about the topic. Thank you.
Thank you so much, Marzia, for the introduction. And I'll get started right away without wasting too much time here. So as we've heard from a couple of different speakers from the WHO, from UNHCR, we know that food insecurity and malnutrition are drivers that hinder the TB response. And we know that undernutrition is a leading population level risk factor for tuberculosis, and a variety of studies have shown this. And here, this is just a small sampling of 30 high TB burden countries from a WHO report. And on the axis here, we see alcohol use, diabetes, HIV infection, smoking, and undernutrition is all key determinants for TB. And the green band is where you see undernutrition as a key factor in most of these countries. So undernutrition must be considered as a key factor that urgently needs to be addressed and prioritized in our global TB response. This slide here was developed a little bit in collaboration with the London School of Hygiene and Tropical Medicine, and a close friend and colleague who's on the call, Delia Bacha, has been helping WFP with this work. And here this slide really just illustrates how food insecurity and malnutrition through a variety of different pathways can influence and lead to TB incidence and mortality. So first we see how food insecurity can lead to poor quality of living, as negative coping strategies such as selling assets can lead to poor human development and overall poor living conditions. Secondly, food insecurity can affect households and individual capacities to access timely and quality TB care, mainly due to prohibitive costs, which can delay diagnosis and treatment initiation. Next, insufficient food intake is directly correlated with TB progression, impairing treatment adherence and increasing overall mortality. Finally, low quality of food intake. High caloric foods and anutritive foods can contribute to diabetes, depression, anxiety, poor overall health, which can lead to multiple overlapping diseases that can occur as health syndemics for those living with TB and other conditions. So now that I think from what I've shared and what we've heard earlier, we've established how critical food and nutrition support our TB, I'd like to just touch on a couple examples from WFP, where our work in the TB response mainly focuses on nutrition programming for individuals, which helps support successful treatment adherence, and our food security and nutrition sensitive social protection programming for households, which help mitigate the impacts of TB. For example, our nutrition programming in Madagascar, and we'll hear from one of our regional colleagues after I speak, in close collaboration with the Ministry of Health, provides TB clients with nutrition, assessment, counseling, and support, NACS, as well as specialized food products. In Tajikistan, a program we had between 2014 and 2016, WFP provided food to all TB patients registered for DOTS treatment and their families for a period of 6 months, which helped not only maintain and improve treatment adherence, but also helped provide some financial security and stability for families that were losing income, as sometimes the main breadwinner of the family had TB. So our role in this arena kind of has 3 main flavors, so to speak. We work as a technical advisor, a complementary actor, and a service provider. So as a technical advisor, we can support national actors in policy and program, build capacity, and help generate evidence around TB. As a complementary actor, WFP, through its own programs, complements a lot of ongoing national systems, especially around social protection. And finally, as a service provider, WFP can support national actors by implementing programs on their behalf. So in the next slide, we'll just see a couple examples of WFP's role and a variety of contexts that we work in to support the TB response. So in 2020, together with the Global Fund as a complementary actor, WFP helped distribute nearly $8 million of TB commodities across 8 countries. As a service provider in Somalia, WFP supports ART and TB clients by providing food and nutrition sensitization support. In Malawi, as a technical advisor, we've supported the Ministry of Health with advocacy and guidance for national plans. In Djibouti, as a technical advisor and service provider, WFP gives nutrition support to TB clients and advocates for the inclusion of TB clients and their families in national social protection schemes. And in Madagascar, WFP is working closely with the Ministry of Health and the National Institute for Nutrition and Public Health to conduct food and nutrition security vulnerability assessments and support TB clients with NACs if they're found to be malnourished. So what can we take away from our work in the TB space as a way forward? Some of the opportunities that we have are actually around COVID-19, which has highlighted the importance of social protection systems and the essential need to provide socioeconomic support, especially for those living with TB. We absolutely need more robust and up-to-date evidence in country to inform and influence national strategies and plans. For WFP, our operational footprint and last mile ability needs to be leveraged more, and partnerships like the one we have with the Global Fund are very much a strategic way forward. A couple of major challenges posed, and one of them, of course, chief amongst them, COVID-19, has been exacerbating the inequalities and impacts for those living with TB and affected by TB, driving them further into poverty and despair. And that, unfortunately, given my presentation and several of the other speakers, despite a wealth of information on food security and nutrition being a well-established determinant for an effective global TB response, funding and national commitments remain low, which not only impacts the quality of programming, but the operations themselves in general, as the example I cited earlier in Tajikistan was unfortunately discontinued in 2016 due to a lack of funding. So in the essence of time, I think I will stop there and turn it back over to you, Marzia. Thank you.
Thank you very much, Michael, for your presentation. We'll now turn to our last panelist. In fact, one of the underlying principles of WHO MAF-TB is the fundamental role of civil society, people and communities affected by TB, and support groups for people with TB. I would like to invite a WHO Civil Society Task Force representative who has given an important contribution on MAF-TB related work in a number of countries in the European region to share her presentation. So, Ms. Julia Chorna, the floor is yours.
Thank you, Marzia, for introduction. Dear colleagues, it's an honor for me to participate in the meeting. My background is in social policy, and no wonder I see the health as a social phenomenon. As for multisectoral accountability framework on TB or MAF-TB, this is a tool which would foster collaborations between different sectors and will help to address social determinants of health inequities. WHO Regional Office for Europe and the Regional Civil Society Network TB Europe Coalition jointly work on operationalization and adaptation of MAF-TB in pilot countries on Eastern Europe and Central Asia. And as I have a privilege to be a part of the regional team efforts and also representative of Civil Society Task Force, I have been delegated by my colleagues to share the highlights on these experiences. Next slide, please, Marzia. So on the slide, you see the MAF-TB checklist and aligned annexes for baseline assessments, which is the first stage of MAF-TB continuum. And I would like to mention again that Annex 2 was developed and inspired by civil society itself. It was developed by Civil Society Task Force by TB, hosted by WHO Global TB Program, and it measures and helps to measure to what extent the engagement of civil society and affected community in TB response is meaningful, to what extent communities' rights and gender perspectives are an integral part of TB policy, strategies, and interventions. Next slide, please. As mentioned, WHO Europe united the efforts with the Civil Society Regional Network TB Europe Coalition to launch MAF-TB in several pilot countries. So how this collaboration works in practice? WHO operationalized the concept of MAF-TB through input of regional public health, civil society, and community experts, and determined the key stages of implementations. You could see the stages of implementations and objectives for each of the stages presented and outlined at the slide below. WHO Europe also facilitated appointment of official focal points on MAF-TB from the Ministry of Health, and it ensures ongoing technical collaboration and implementation of all MAF-TB stages. And TB Europe Coalition is a civil society network. It takes a lead in organizing a regional expert team which developed a research protocol with auxiliary data collection methods for qualitative data collections, because the checklist, as you say, just like a checklist, yeah, with statements. So it is to be complemented with interviews, focus groups, and surveys. In partnership with civil society and community platforms in the countries, TB Europe Coalition rolled out this field data collection and supported consolidated voice of civil society and community for endorsement of the findings, which are related to Annex 2 through national civil society and community platforms. I would like also to mention here that the role of partnership at global, regional, and national level in operationalization and sustainability of MAF-TB is crucial. Regional collaboration approach is also open to other interested stakeholders, and recently Global TB Caucus has joined on board to pilot the approach of the checklist on involvement of members of parliament in TB response. So we are kind of piloting and documenting all their approaches together to see the regional guidance available afterwards. The next slide, please, Martin. The last one, actually. Finally, let me share some examples of how MAF-TB activities accelerated some progress in the pilot countries, which are Belarus, Moldova, and Ukraine. In Ukraine, joint efforts of national stakeholders, which include National TB Caucus, chaired by the Member of Parliament, MAF-TB focal points at the NTP and Ministry of Health, Secretariat of Country Coordinating Mechanism to work with the grants of Global Fund, civil society and communities have been reflected in recommendations of the Parliamentary Health Committee hearings, which took place in March. Those are to send the appeal to the President Administration to establish annual high-level review and recommendations to the Cabinet of Ministers to ensure the development of the national roadmap for 21-23 on implementation of the mechanism of multi-sectoral collaboration and accountability to NTB. So this is an example of a political support achieved at the country level through MAF-TB processes. MAF-TB developments in Moldova was brought on the agenda of a series of meetings with voluntary national review on achievement of sustainable development goals. One of the recommendations of the first meeting is to sustain the priority of ending TB efforts in the face of health emergencies, and national roadmap resulting from the MAF-TB baseline assessment should account for SDG voluntary review recommendations and be synergized with SDG-related processes where appropriate. Also, discussions on meaningful engagements of TB civil society and community response related to participatory filling of the Annex 2 brought into the highlights examples of increased role of civil society in TB detection, X-ray screening, and media-supported treatment scale up during the times of COVID-19. It is important to anchor the role of civil society and community organization within the TB response based on these examples and further agree on the multi-sectoral coordination and mutual accountability for performance and outcomes with national TB programs. So MAF-TB mechanism is seen there as, with all the aligned processes as a practical tool to make it happen. And in Belarus, there is an example in Belarus, there have been collaborative work of NTP and CCM Secretariat on coordination of MAF-TB processes, and there have been a round of consultative meetings to fill in the Annex 3 with the preliminary recommendations which are subject to official national endorsements, one of which is to include establishment of the working group for complex assessments of the alignment of WHO TB guidelines to national protocols and strategic documents, and inclusion of the provisions of the WHO TB guidelines in the national strategic documents relevant to country context. Implementation of this and other recommendations will strengthen the process of further revision, adaptation, and alignment of national protocols to WHO guidelines. So that's kind of a practical outcomes. And a couple of concluding work, I would like to point out that in pilot countries of the ECA region approach, baseline assessment exercise itself has become a capacity building, collaboration strengthening, and awareness raising process. It was built on participatory approaches, as I said, and it enables social participations of all interested stakeholders and also ensured country ownership. And to have MAF-TB processes sustainable in the long term, it should become an integral part of TB NSP, both as applied to its revision and development, which already happened in some countries, and be supported by donor-driven and national funding committees. So in general, WHO Europe, based on the results of piloting, is developing a regional guidance on operationalization of MAF-TB processes to support more countries and national counterparts to adopt the approach. We see the MAF-TB as a living tool, which should be flexible and able to adapt to the changing context, and suggest to have the process for updating the MAF-TB tool itself and approach based on piloting and implementation of first round of baseline assessments in countries of all 6 WHO regions. My acknowledgement and gratitude to Dr. Serhat Haskanova, WHO Europe, and Yulia Kalanchai, Executive Director of TBEC, for their contribution in development and support of this presentation. Thank you for your attention.
Thank you, Yulia. And let me thank you all the panelists for your great variety and rich presentations. You can turn on your cameras if you want. And although we are a little bit late, we would like to still try to go for a Q&A session. So the panelists has already replied to some of the questions in the Q&A box, but there is one that maybe we can go and try to answer now. So the question is for Dr. Kazaeva, and he says, in the countries with a strong and active multisectoral approach, who has taken lead in bringing the relevant sectors together? How did they ensure different sectors remained actively engaged? And for example, through the use of memorandum of understanding, terms of engagement, which tools were employed?
So thank you very much. A very good and concrete question. First of all, we expect, and based on the commitments made at the high-level meeting on TB, that there will be highest level of engagement and prioritization of MAF-related approaches and activities, at least in the high TB burden countries. It means that there should be ownership and oversee by the presidents or the prime minister or by the parliamentarians or any other high-level officials. So as high a level, as better result we can expect. And that's why creation of the high-level commissions under the supervisions of the presidents or prime ministers or any other high-level officials would be absolutely essential for pushing forward and driving further this agenda. We can see in the example in the countries with the advanced multi-sectoral collaboration that framework is becoming kind of temporary mechanism to bring all the relevant sectors together to agree and to establish these clear principles of collaboration, to put clear indicators and identify relevant funding, not only from the health sector, but beyond health sector. And some specific health-related activities should be embedded in the portfolio of different relevant sectors, ministries, and stakeholders. Once these principles are formalized and it's seen as working on sustainable way, then I think there will not be such a need and necessity in this mechanism. There could be a way of regular monitoring of the progress and reviewing the progress by a smaller group of the representatives of these stakeholders and agencies. And of course, civil society role, as we can see from Yulia's presentation, is absolutely essential. So this will be my response to this question.
Thank you very much. We have another question. This one is on the SDG 3 gap. How can the SDG 3 gap support multisectoral collaboration among multilateral agencies at country level? Maybe Zadora can take that.
Thank you, Marta, and thank you for the question. So the Global Action Plan is really a commitment of 13 multilateral agencies to work closer together. And it's recognized in the document itself that multisectoral and cross-sectoral action is needed to achieve many of the health-related SDGs. And so many of the accelerator areas, which I very quickly showed on my slide at the very beginning, are actually cross-sectoral and multi-sectoral areas. For example, PHC, primary healthcare, determinants of health, but also community and civil society engagement. And so basically, the idea is really to leverage the commitments made by the principals of all of these agencies to strengthen collaboration, including across sectors. So across agencies that maybe have not been used to collaborate so much before. But the Global Action Plan can provide this platform and an opportunity.
Thank you very much for answering this. And we have another question for Julia Chorna about sharing some examples of the national roadmaps from the assessment. Julia, do you want to take that?
Yeah, sure. Thank you for the question, and thank you, Marcia. The thing is, now in the pilot countries, we are at the stage of consolidating the findings from their checklist and those realigned annexes. It should result in the consolidated report as the next and endorsed by the national counterparts. And based on the findings and recommendations of this consolidated report and endorsement achieved, then the next step is the development of the roadmaps. So we are in the process of this. And as for the monitoring and evaluation tools, I would also like to mention that MAP-TB assessment should not be the one-time exercise. It should be repeated with some periodicity in order to to measure the dynamic of change. What has changed since the baseline? So repetitive introduction of the assessment with some periodicity in a couple of years would also serve as a monitoring and evaluation and a measure to tackle the progress. So once the roadmaps are available and once we finalized the regional guidance based on these pilots, we of course will be glad to share with all interested stakeholders. Thank you.
Thank you very much, Julia. Afsar, we saw you answer to a question in writing, but maybe do you want to complement that? The question was about how easy it is to enable collaboration with employers and with Ministry of Labor and Employment.
Thank you. As I said in the response, indeed, it's not always easy to motivate employers and engage them in the program because they have their own priorities. But we adopted a few strategies which seem to be working well. One is to get them closer to the national level dialogues with the Ministry of Health, Ministry of Labor, where these national priorities are discussed and the role of employers are highlighted clearly. So having a national policy framework which outlines the role of employers clearly and also says that if employers come forward, how can the departments and ministries of health will work together with those employers? What was it to start? Second thing that we did was to pick up those companies which have already done some good programs on TB and HIV, and we built them as models, as good practices, and documented their work, invited them to talk to other employers in different meetings that we organized. This was also very useful because number of companies then understood, yes, it's possible to do, it's an easy, doable kind of a thing. In fact, I would also like to share that one company said very clearly that since we were already working on TB and HIV programs, we had peer educators trained, we had a policy framework. This allowed us to deal with COVID. When the COVID situation came up, this preparedness helped a lot. And this is a good time. So I would also suggest that now that most of the enterprises are worried about COVID and they're planning to restart operations as soon as possible. So taking the COVID route and integrating, adopting a more kind of a multi-disease approach would also be a good idea. And the last thing which worked was when they talked to people who had TB and they got better. And then when they said, your support, the support that I received from my employer is always helpful. So this also moved them more on a humanitarian, human level, and they came forward. These were some of the things that seem to have worked. But yes, it remains a challenge. And the most important thing is to provide regular technical support. Provide them trainings, use the existing structures that most of the enterprise and employers have. Sometimes they have health setups, Sometimes they have their own structures, so build their capacities so that the programs become more sustainable there. Thank you.
Thank you very much, Afsar. I think that we are already running late, so maybe we close here the Q&A session, but please send us your other questions, if any, by email. The panelists and us will be happy and ready to answer. And also I invite you to join the interactive platform on multisectoral accountability, on the multisectoral accountability framework. I shared the link in the chat, so you can register via your email. We'll follow up on the questions there as well, and more information will also follow. So let me thank you once again, all the panelists and all you attendees, and I hand over to Teresa for some final words. Thank you.
Yes, thank you very much. And first of all, distinguished panelists, dear colleagues and friends, it was excellent journey, almost for 2 years, or for 2 months, or for 2 hours. Sorry, I would like to have it to be continuing all these efforts. And so thank you very, very much. And you see that more than 120 participants were with us, and still more than 100 are still there. And we can see huge interest to the topic, a lot of questions, and definitely we will continue sharing useful information. All the presentations, responses to your question will be shared via panel, via platform. A link will be shared in the Q&A section. Please, Marcia, forward the link. And what I would like to say, it's obvious, of course, that the benefits from the multisectoral collaboration are obvious and clear, but it's easy to present, to explain, but it's not sometimes easy to implement. And that's why our joint forces, our awareness is absolutely critical, because we should advocate to the highest level officials. We should learn lessons from the COVID crisis and try to use these new innovative approaches, because the world changed dramatically. We can't continue doing business as usual, and TB is not only the problem of the doctors and patients. It's the global, big, long-standing problem, and it could be solved. We have all the tools, instrument. Still, lack of prioritization, a lack of funding for sure, and a lack of integration. We have very good examples. We should uptake them. We should use them more actively in terms of drivers of this process. As we can see, that they could be different. It depends on the country situation. In some countries, definitely civil society play leading role. In other countries, parliamentarians are active. In other countries, joint efforts of the UN agencies can make a difference. And of course, WHO is fully taking all the responsibility to continue coordination and providing leadership and guidance in this process. So we are very positive about perspectives. So let's stay together, and I'm sure that we will do better, because we have no other choice. We must do better, and we should achieve our NTB targets and support to the people. Thank you very much. Staying in touch, share your ideas, how we can work together better and improve our multi-sectoral collaboration. Thank you, colleagues, once again.
Thank you all. Thank you, Teresa. Thank you all the panelists, for attendees. I think we can close the webinar of today. More will follow. Thank you. Bye.
Thank you. Bye.